We ready? Yeah. Great. Good afternoon, everyone. Welcome to this meeting of the Health and Wellbeing Board. I'm Councillor Jo Coles. I'm the Executive Member for Health and Wellbeing and Adult Social Care. I actually thought we've got quite a number of new people around the table, so I thought we would just do a very quick round of introductions, not least because our new Director of Adult Social Care and Integration is at the table, and therefore you'll all know who she is, and more importantly, she will know who all you are. So I'm Councillor Jo Coles, and I'll go this way first, if that's okay.
Thank you. I'm Councillor Carol Ransom, and I'm the Executive Member of Adult Social Care and Public Health.
I'm Councillor Andrew Waller. I'm Shadow Executive Member for Children's and Education.
Thank you for the welcome. Sarah Story, Corporate Director for Adult Social Care and Integration. Thank you.
Good evening, everybody. I'm Sean Balsam. I'm the Manager of Healthwatch York.
Hello, I'm David Harborne. I'm Chair of Trustees at York Centre for Voluntary Service, and I'm standing in for Alison Sevens, who is on leave today.
Hello, I'm Brian Cranner, the Director of Operations and Transformation for Tees Esconvere Valleys in North Yorkshire and York.
Hi, I'm Peter Roderick. I'm the Director of Public Health at City of York Council.
Hi, I'm Emma Broughton. I'm a GP in York, and my role here is to represent the York Health and Care Collaborative.
Hi, I'm Caroline Johnson. I'm Deputy Director of Nursing for York Place, and I'm standing in for Sarah Coltman-Lovell.
Hi, I'm Tracy Wallace. I'm the Health and Wellbeing Partnerships Coordinator.
I'm Ben Jewett, Democracy Officer.
Literally the most important people in the room because they keep us on track. I've got apologies from Councillor Webb, who has a work engagement, Councillor Eyre, Chief Constable Winwood, and what's DCC? Detective Constable? What's that?
Deputy Chief Constable.
Deputy Chief Constable Hussain. Zoe Campbell, who has got a substitute in Brian Cranner. Sarah Coltman-Lovell, who has a substitute with Caroline Johnson, Alison Sevens, who has a substitute with David Harborne. So welcome everybody, and thank you for attending and giving up your time. Thank you. I'll also just introduce, because he's missed the opportunity to introduce himself, Martin Kelly, the Director of Children Education, Corporate Director of Children Education, who is also joining us. Brilliant. So thank you all for giving up your time. We are going to try and use our time effectively because we've got some important people in the room. And also just having as an open discussion as we can. And I also just wanted to remind people of the purpose of the Health and Wellbeing Board to improve the health and wellbeing of people in the City of York and to reduce health inequalities, which are, for the record, 11 years for men and 11.2 years for women between, I think, the wards of Westfield and Cotmanthorpe, which are 2.5 miles apart. So thank you, everyone. And I'll just move on to agenda item 1, which is declarations of interest. Does anyone have any declarations of interest relating to any of the matters on the agenda today? No? Ooh, great. And I'll move on to the minutes of the meeting held on the 24th of January, which is agenda item 2. Did anyone have any corrections to those minutes? I mean, I had a point of accuracy around minute 173. You don't need to correct it, but that the Independent Care Group had stated that the recent announcement of £500 million of central government funding for social care could ease the pressures of budgetary cuts within the care system. I mean, it can't really. So we should just be clear about £500 million nationally. It's not £500 million for the City of York. It barely touches the sides in the City of York, the proportion of it that we got. It certainly doesn't solve our social care problem. I didn't have any other corrections, in which case, does anyone else have anything else they wanted to raise in relation to the minutes of the last meeting? Okay, I will sign those at the end of this meeting. So I'll move on to agenda item 3, which is public participation. And we have one public speaker this evening, who is Hazel Kerrison. Hazel, I can see that you're here. If you'd like to come up to the table, you will have 3 minutes. Would you like me to, it is 3 minutes, isn't it? Would you like me to give you a 60-second warning when you're, okay, lovely, yes, I can, definitely, but you're very welcome and the floor is yours for 3 minutes.
So I'm here to talk about a different topic today, yay, which is the mortality rates of people with severe mental illness. Now, I myself have schizoaffective disorder, which, if people don't know, is a bit like having bipolar and schizophrenia at the same time. That's a massive oversimplification, but that's what I'm going to go with because I've not got long enough to explain it to you. Now, over the last 4 years, there's been an increase in the excess deaths of people with severe mental illness. Now, this is national, but the local numbers are far higher than the national numbers. Just to give you a bit of context, our current ones in York are 425%, whereas national is 344.2%. I'm not going to blind you statistics. It's you know, it'll bore you all. But the issue I have is that the only risk factor, well, the issue I have is that people should be dying. But the second issue I have is the only risk factor listed is the increase of people smoking. Now, I'm not saying smoking is not a risk factor, definitely is, but it's not the only risk factor. So I did some numbers. I said I wouldn't blind statistics, but here's some more anyway. People with severe mental illness are 6 times more likely to die from respiratory diseases, 6 times liver, 4 times cardiovascular, 2 times cancer. Now, other things also make these more likely. For example, the side effects of antipsychotics, they are a massive risk factor. Socioeconomic issues, the late diagnosis, irregular healthcare, non-compliance, discrimination, self-care issues. There's an awful lot of things that this is not taking into account. Smoking is one thing, but there are hundreds of things that can cause you'll be more likely to die from these things that I've just listed. And that's not even taking into account things like suicide, which we can't avoid. We can't avoid, that's badly worded. I should have written a script. So we can't avoid talking about it, as horrible as topic as it is. The peak of suicide when it comes to severe mental illness is either during or just after admission to hospital. There's got to be an issue there. When you are discharged from hospital, it's quite a cliff edge quite often. I've been myself, I'm fully aware what it's like. But there's other things that we've got to take into account. So when I go to a GP with any sort of physical disorder, they assume it's my mental health. There's an awful lot of people being quite complex. Someone who has a severe mental illness is quite likely to have at least 2 physical disorders on top of that. And that's when before you take into account things like lifestyle choices. I hate saying lifestyle choices, but that's the official terminology, so I'm going to have to stick with it, unfortunately. So what I'm saying basically is that there's far more involved in smoking. Annual health checks are great, smoking stopping programs are great, but there are more things that need to be looked into. I should have written a script, and I'm really sorry that was quite rambling.
You are very welcome, and thank you for your contribution. Hazel, you're welcome to write to us at any time as well with any of those additional points if you wanted to, but we will take those issues into consideration when we reach those items on the agenda today. I will then move on to agenda item 4, which is the Chair's report. And I just wanted to draw people's attention to a couple of elements and also a couple of amendments to, I think, the original published papers. The first issue I just wanted to draw people's attentions to was agenda item was point 6 in the report around pharmacy provision, which actually is becoming an increasing concern. There was a specific issue in the city in Clifton, which I know that both the scrutiny committee and councillors Myers and Wells in that ward have been looking into closely, and we're hopeful that there'll be some progress in that particular area. But there does seem to be a wider pattern around smaller pharmacies in particular, particularly the large chains who have small pharmacy units in the city. And so if anyone has anything that they want to add, I guess I'm also thinking particularly about primary care, because it will be a particular problem for primary care colleagues. I just wanted to draw people's attention to that. And then separately, just the annex to the report is an update on the dementia strategy, which I am really worried about. I'm particularly concerned about the diagnosis lag and the impact that that has on adult social care and on carers, because the longer the diagnosis takes to be formalised, the longer people may be taking to access support and any medication that may help to alleviate symptoms. I'd be also welcome anyone's additional comments they could make about that anecdotally in terms of what they're seeing in the city. And then just in terms of the Better Care Fund report, I just needed to update people on the first section of that report in Annex B. The published report, there is a slightly amended version, which I will just read for completeness. So the City of York and the ICB collectively oversee £21.7 million worth of spend. £14.8 million of that is of the community services budget, and 15% of the community CHC and FNC budget. It is around 2% of our total York Place budget across health and social care to support system flow, maintain independence, reduce hospital delays and admissions. I am slightly troubled by something in here that said, I think that they weren't, maybe it's not in this report. Oh yes, there's another amendment on the second page of that report, around the paragraph that begins the BCF project manager. The end of that paragraph on my amended version says there is no pressure on the BCF budgets. We have been managing this within the 21.7 million. The ICB is on track to deliver its overall 23-24 ICS financial plan. I find that quite a troubling fact as well. I would have thought that is not our ideal budget in terms of how we deliver things, but again, maybe if people have things that they can add, and maybe I've misunderstood what I read, but I can't believe there isn't pressure on the Better Care Fund budgets, but I'll happily be corrected by anyone who thinks that we aren't. So that is the report. Those are the things that I wanted to draw attention to, but did anyone else have any issues in that report that they wanted to pick up on? Emma? Yeah.
So I guess mine was more comments during one of some issues you mentioned. Yes, the pharmacy issue in York is a real concern for primary care, and I guess we'd welcome the opportunity to be more involved, perhaps in the solutions here. I think there are several things we can do with regards to trying to help, particularly the elderly and the vulnerable, who need to be able to access. If you're looking at 2 bus trips from Clifton to get up to Clifton Moor, this is not something our elderly population can do, and they're on the highest likelihood of being those on regular medication. So certainly I know for Priory, Rawcliffe branch are trying to work with some local pharmacies, and I know York Medical Group are too, so they're practices in that area. But I just want to highlight it's a real concern, but we can look at sort of more novel approaches which might involve deliveries to either Amazon type lockers with general practice, but ways of trying to get those medicines available. But I do worry about the general direction, given primary care's solution at the moment to the capacity issues is pharmacy first. If there aren't any pharmacies to send to first, then we are being all set up to fail. So I think it's just that we have a very good connection with the York pharmacy. So again, just to come on to, that's something we'd welcome doing more work with, but we're also cited on that. And then the other one I just wanted to mention about the dementia piece of work. York Healthcare Collaborative are trying to do an initiative not just about looking, trying to improve the diagnosis rates, but also to look at the carers. And I think this is something really, I guess, collectively, we would really welcome from a primary care perspective. We are not offering perhaps the physical health care to carers that we could do because we don't know who they are. So I think there's a real direction that we're trying to look at to try and improve coding and raising awareness. So again, it's anything this committee can help do to it sounds the simplest thing, but just let your GP practice know you're a carer. We know 68% of unpaid carers are female, and it's massive, both a female to male health inequality there, as well as the physical health element. So this is particularly pertinent to dementia. So I guess anything we can promote as an organisation and across boundaries to just say it's as simple as, please just don't assume that we know that you're the carer to your elderly relative. We don't. If we do know and we code you, we'll invite you for flu jabs. We know that there's extra healthcare that we can provide. So I guess it's two issues just on those. I think are really important topics. Thank you.
Thank you. Councillor Runciman.
Thank you. 3 points, Chair. Pharmacies first. My particular concern is pharmacies in the villages. And I've already had a quick word with Sean about actual access to pharmacies. So there's the access between village and village, say, which is a problem, which I'm sure you know about, but there's also access for people in wheelchairs, where there's, say, a step or 2 steps, perhaps more, or with limited mobility. And I was pleased to hear Sean tell me that they are going to look at that. But I think those 2 access issues, the actual getting there, and then when you get there, whether you get in the door and out again, my last experience was I had to help somebody do that, is really important. The second thing I wanted to say is about dementia strategy. And I think we need to get the message out to people with dementia, or who may have dementia, that help is there before a diagnosis. And that is really, really important. I worked with Dementia Forward to make sure that was apparent. And I think some people, I think they suffer in silence. Going back to your carers point, they think they have to put up with it, but there is help available, and it is available before a diagnosis. And my pet hate is having to wait for a label. And you shouldn't have to wait for a label. You should get the help you need when you need it. And then my third point is about the BCF update. I couldn't get down all the points you said. So could you possibly circulate a revised version of Annex B so I can sit and contemplate them at my leisure, should I ever have any? Thank you, Chair.
Thank you. Yes, and we will circulate that amended Annex B so that everyone, if they have other points to raise, can raise them when we approve the minutes. Sean.
Very quick, slightly annoying quibbly point, but could we always make sure we left justify any reports? For some reason, all of the others are fine, but this one, a lot of it is spread across the page and it makes it harder for lots of people to read it. So
noted. Thank
so
you.
If we're recirculating it, we might as well make it look better and easier to read as well.
Yeah, I'll pick that up separately. Thanks. Did anyone else want to come in on this particular report? In which case, I will move swiftly on to the report of the York Health and Care Partnership, which is agenda item 5. We have Peter Roderick and Caroline Johnson on this item. I will let you decide between you who is going to go first.
Thanks, Chair. I'll kick this one off and getting my excuses in early, in that Sarah Cotman-Luffel would usually be doing this report, and Carol and I will do our best to be super subs on this particular one. The board will be aware that the ICB's Place Board, the York Health and Care Partnership, has committed to bringing a report to this public meeting every single time, updating on the work that the partnership does, and covering the ICB's place work at York level. And that's what this report does. It lays out the different bits of the place plan, the 6 key priorities of the York Place plan, and talks about the progress that have been made against them. So it starts off by talking about York's integrated community offer, and mentions a number of different new schemes which are emerging and I think are getting broad support from partners, and probably will grow into the future. I guess where we're thinking about particular cohorts of individuals where more integrated approaches produce better outcomes, particularly in terms of admission avoidance and facilitating discharge. So the two that it covers are the Frailty Hub, which has been launched at Acomb Garth with GP input, with local area coordination input, social prescribing input, and the extra discharge support service, which is provided by the CVS, which works alongside it. The second of those is the urgent emergency care offer, and a number of strands of work under the combined urgent and emergency care North Yorkshire and York board, which is currently coming to fruition, particularly in terms of the way we run our urgent treatment centres at York and Scarborough, with quite a lot of transformation in those areas. The third is around shared primary and secondary care models, and the work that has been done over a number of years in York. We've had a very strong referral support system, which has been under a slow transformation into I guess a model which is around rapid expert input into the way in which primary care refers into secondary care, and the way the two work together to make sure that people get appropriately seen. Obviously, over the last couple of years, the thing that has become most apparent nationally has been the length of time that people wait between being referred and being seen for first outpatient appointment or getting their treatment. So the item there explores a number of sort of projects which, you know, ultimately, unfortunately, don't by themselves solve the waiting list issue, which in many ways is a product of a number of issues, but do seek to make the pathways between primary and secondary care as clear as possible, but particularly the care is shared, and people are seen in the right bit of the system. The next priority is about an inclusive model for children, young people and families, and some of the work that is summarised there, particularly about supporting children with language communication needs, and the work of the quality group around that issue. The next is about the integrated prevention early intervention model, and a piece of work that the partnership received back in October, which is still being carried out, looking at issues around prevention when it comes to the workforce of staff members who work in preventative roles, the way in which we fund preventative roles across the system, the way in which we monitor and evaluate prevention, and increasingly, I think, needing to see prevention be able to demonstrate the ways in which it can help reduce demand within the system, but also retain, which is something it's had for a long time in York and is a real strength of our system, which is a strength-based approach to prevention, not merely looking at people's needs, but looking at people's strengths and having that default. What can the community do? What can families do? What can networks do in order to prevent ill health? And then the last bit of the board's place priorities are around driving social and economic development. And the work that we've done over the last few months. I would pull out here some work, particularly on work, literally people's jobs and their health. And we're now at, I think, 2.8 million people nationally who are out of work due to ill health, and some significant new programs, particularly within the mental health and the addictions world, around what's called IPS, individualised placement support. But we currently have a bid in as the ICS to something called the Work Well program, which is a much wider piece of work to try and support people with long-term conditions back into work as and when that's possible and appropriate. So we haven't heard about that, but I will update the board if we're successful in that bid. Then the most recent meeting focused on mental health, and it's here that I'll probably hand over to Caroline, but just to say a really good meeting where the chairs of our mental health partnership, so Stephen Wright and Professor Lynn from York St John, came to talk about the mental health partnership being aligned under the place partnership and what that will mean. We discussed the mental health hub. We discussed a model from North East Lincolnshire, from Navigo, around community mental health and had lots of ideas for the way in which the place partnership can give the mental health partnership its sort of steer on that. And at that point, I think I'll probably hand over to Caroline for any further comments, particularly, I guess, Caroline, on that mental health piece and the conversation that we had there.
Caroline, you need to just put your mic.
Yeah, what I would say is it was an absolutely superb meeting. It was really focused around mental health, and it was really, as a mental health nurse, it was really heartening to hear a whole meeting focused around mental health and the real passion within the room to actually make a difference. One of the things that's within this report you'll see is there is a proposal which was supported at the meeting around the realignment of the York Mental Health Partnership from this board, the Health and Wellbeing Board, to the York and Health and Care Partnership. And that was to ensure that we were really aligning the work of the group to absolutely focus on mental health and driving mental health forward within the city and realising the values and the vision of the partnership. In terms of the hub, there were some really fantastic presentations around the mental health hub, and the mental health hub is absolutely within its pilot scheme has really tested out how we can co-design and come together within the city to provide almost that one place where people can come and receive support for their mental health issues. And it's been delivered alongside other services within Clarence Street to date. And the prototype hub has faced several challenges over this time, but it's helped to actually shape that model and sustain model over the coming months. And so there's a plan to roll that out further to other hubs across 12 to 18 months. And there was also, we heard about a visit to Navigo in Grimsby, which is really, when you listen to the visit and the feedback from the visit, what an amazing model Navigo have developed over in Grimsby, which really places mental health at the heart of the community and really thinks differently and broadly about how mental health care can be delivered, and really giving people opportunities to be able to access work, to be able to really sort of think about how they can move forward in spite of and despite some of their mental health difficulties. I'll pause there for questions.
Great. Does anyone want to come in quickly? Yes, Councillor Waller.
Thank you. Just picking up on the speech and language professionals, it would be interesting specifically with improving access referrals, because that's a key part of the early talk for York. And I know that some schools say it's been helpful, but there is still a bit of a waiting list. And so just understanding what's being done to address that specific.
Caroline. Sorry, Martin, do you want to come in?
If you don't mind. So yeah, I think in terms of the early talk for York, I think we are looking, there's two aspects of early talk for York. One is that we train the wider workforce to understand the identification of speech language communication, and another aspect is to identify it and to provide some intervention in schools. I think what we've found is that perhaps the first part is at times potentially increasing the waiting lists because it's identifying it and passing it on to the specialist services. And we're probably more interested to understand what the benefits are of the second aspect of training, which is the intervention, the wider intervention, because what we're not going to see, not just in speech and language, but actually across a range of domains, is a whole load of specialists coming to the city that just don't exist nationally, and trying to just chase that rainbow isn't going to work. So we are doing some work to look at early talk for York and to try and understand the benefits of the latter part of how do we make sure that more people are able to intervene rather than just identify it.
Thank you. Can you hear Councillor Runciman when he's talking? People are talking in front of laptops. Yeah, so if people could just be aware that if you have a laptop, that's fine, but can you move your mic to the side so that people can hear? Emma.
Yeah, so I just want to come back to one of the things on the Health and Partnership report. There was about shall I call it winter pressures? Again, we have this conversation every year. Winter comes round every year. Every year we wait till about the 5th of December, at which point we commit some funds, and then we ask generally primary care to step up and suddenly provide services. So yes, great, we had it again this year. It's happened every year, various amounts, but I guess I would have an ask of some bold courage from the system to say it is going to happen. Why not plan this year for it, as in opt out rather than opt in, and potentially step up and down? The reason I say that is, although it's great we had an offer this winter, which did help obviously massively with A&E and general practice pressures, which were ginormous this year, but it was very expensive and it was very poorly utilised. About 50% use of the YAS GP, 50% in the hospital, because we couldn't step up quick enough and because the pathways weren't there. So I guess it's a plea of the system to plan for this coming winter, that means that we can put professionals in the right place, plan for it in advance, and then you can do it in a more economic, you can get just better use of the money that we've got as a system. I know the challenge every year, no one knows what the money will be, but there will be some funds every year. And I say, we've come across it again this year. So not been used as well as it could have been, and it's been a very expensive offer. Could we do differently and braver this year? Thank you.
Peter.
Just to come back on Emma's point, I think it's key, isn't it? We did last year, and we said to ourselves, I remember someone saying this in a meeting, say winter starts on March the 1st, and that's when our planning should start. And to be fair, it did, and an operational group was stood up that Sharon, my predecessor, chaired for a while around winter pressures. And I think actually our approach to things like public messaging, vaccination, the things that we had in our control, we did do at an earlier point last year. And you're absolutely right, Tyler. The thing that was hardest was the thing that was waiting for NHS England to announce its winter pressures funding. That becomes very difficult. So I wonder if the ask of the ICB is to hold earlier conversations about almost what the best buys are earlier in the year, so we are prepped and ready to go. Because if it sounds like the feedback from primary care is some of the things that we use that resource for weren't utilised to the greatest extent, we need to take that learning at this stage and understand, if our winter pressures fund was $500,000, we'd spend that first $500,000 on this, and then the next half we'd spend on that. So almost that sort of next best thing approach. So I'm happy to take that back. Sarah, I'm sure we'll get the minutes, but to highlight that to Sarah as an approach that primary care would advocate.
Thank you. I've got a number of people waiting to come in. Just on that particular point, Peter, I'm just wondering whether actually that point around having the kind of the shopping list, for want of a better word, of what we actually are ready to deliver and how much it costs, having that ready early and communicating it nationally, as in, this is what we're planning to deliver, this is what it costs. But if you can't give us this much, this is the absolute basic, this is the minimum that we think we need to get through the winter. Then just whatever form that takes, I think we should probably be more proactive in how we respond to that, given that this will obviously keep happening, and actually maybe even worse this coming winter, because there may have been a general election getting in the way immediately beforehand. I'll take Sian and then David and then Councillor Runciman I've seen as well.
Yeah, it was very much that point I wanted to come back on, because talking of conversations we've had too many times but haven't resolved. We had a massive conversation about risk, our appetite to risk, doing things at risk, knowing they're a risk, when the NHS funding is never given to us at a timely point where it would be helpful. So I think we do need to have a clear understanding of, will we do things at risk where it's the right thing to do, where we know the money will come down, and can we justify that, and how do we fight that fight at a national level to say, we can't wait for you. We know this every single year. So I'd fully support us saying, these are our wish list. These are the things that are essential. We are going to put the essential in place, whether or not the money has come down, and we'll gratefully accept it when you finally release the money that we know should be here. Because we were having the same conversations at the moment with the Humber and North Yorkshire Health and Care Partnership about the fact we still don't know what the settlement is for 1st of April. It's ridiculous, but it's a fact. And we all have to deal with that. And we can't just stop every time this happens. So we have to make some decisions about us saying, we will hold the risk, we will go with it, we will do the right things, regardless of the systems around us.
Thank you, Sian. Yeah, I couldn't agree more. David, do you want to come in?
Thank you. Everything Emma said, but replacing primary care with the voluntary and community sector. There is this expectation that voluntary and community organisations can step up just like that. We are really keen to help with winter pressures and all of the things that we discuss around this table. But the idea that we have people just waiting to be funded is astonishing, and we don't. So it's a miracle we get anything done when money is given at such short notice. It also works at the other end, that if a contract has been awarded and then a decision is taken by the commissioner to review that, but we don't get the outcome of the review until the contract has ended, our staff have already left. We have had that at York CVS. I didn't raise it earlier because I'm not making any special pleading for the organisation I represent, but we had 4 social prescribers in the hub. And we were then told that Ways to Wellbeing was under review. We had no choice but to put those staff on notice of redundancy. As a result, all 4 have either left or moved to other jobs. So I don't know the outcome of that review. I'm not asking for it now. But the fact is, if the service is going to be renewed from the 1st of April, there will be no staff to deliver it, and there will be a new recruitment round. And these are the sorts of issues which go on round and round and round for the voluntary and community sector, because public sector commissioners do not understand how to commission effectively from our sector, despite the fact that the work we do is valuable. Thank you.
Thank you. Just before I bring Councillor Runciman in, I'll just pick up on it while you've said it, because I had it as a note to say anyway. I had picked up on exactly that point. I actually raised it earlier this afternoon in the Health and Care Partnership. Is that where Sarah is? She was there in person. I was virtual because I had to come to this. But I raised exactly that point about the voluntary sector not being able to operate with the uncertainties that are hoisted upon them by funding arrangements, and that you do exactly what you just said, David. You lose staff. We lose staff as a city because we lose their expertise. We lose that continuity. Residents therefore lose that level of support in the city, and then someone somewhere wakes up to the fact that we have a problem and signs another check, and then someone has to start recruiting again, and it's a completely inefficient way of organising things. So I absolutely have already picked up on that point and raised it earlier this afternoon. I think it is a real problem for health colleagues who with all due respect, don't live in that world of uncertainty of job all the time, and I think there are some lessons to learn, I think, just in terms of partnership working and seeing things from the point of view of all those partnership organisations. Councillor Runciman.
Thank you, Chair. I couldn't agree with you more. And David, you're absolutely right. And we've been putting up with this for years, haven't we? Very difficult. People seem to think that because you're voluntary, you're not paid. But actually, of course, it's not true, because there's always a mixture of paid people and people who volunteer without being paid. But I just wanted to say something else, which is I was very pleased to see right at the end of the report about early intervention and prevention approach. That's exactly the way we should be going. It saves money and time later on when things get more serious. But as the mental health hubs develop, I would be pleased if a report will come back to the Health and Wellbeing Board saying where they are, because I think when they're there, when they're ready, we need to be saying this is where they are. You can get a bus to it or whatever. That's the advantage of the Acom one. It's very, very accessible, and we always have to think that a lot of the people that go to the hubs like that are not likely to be driving a car. They're much more likely to walk or come on a bus. So if we could just hang on to that one and hear more when more is planned. Thank you.
Thank you, Councillor Runciman. Martin?
Just wanted to introduce a slight voice of public body reason. So just to slightly defend that it isn't always about incompetence of commissioners. I think what we find is actually it's exactly the same behaviour happens in public services, including local authority and many parts of the health service. Fundamentally, it is about how funding is trickled down nationally at times. And I think we've seen, probably in my career, the last 10 years of austerity has resulted in lots of temporary funding, which is grant funding rather than permanent funding, as well as the fact that Treasury often make very late decisions. So sometimes we've got literally weeks, that we're given money weeks before we need to spend it. And that goes right across public services as well as those services that we commission.
Yeah, thanks. I just had one other point that I just wanted to raise around the mental health hub, and just whether anyone can add anything around what we can expect to see when the hubs are more established in terms of numbers of people being seen or the quality of support that they can expect to be available, and just also any update on the mental health crisis and emergency care, and our ability to respond effectively and appropriately on that. If anyone has any updates, I would appreciate them. Brilliant. Brian, if you could come in, that would be great.
Yeah, I'm happy to give an update on that. So in relation to the mental health hub, we're on track to be relaunching that at Clarence Street next month. Posts are fully recruited too now, so we've got mental health clinicians, recovery workers, support, social work input within that service. And we'll be, as I say, up and running throughout April. There'll be a phased introduction of it, and that's part of that sustainable model going forward at the moment to 3 hubs across York, which will be implemented as safely as possible, as quickly as possible, but as quickly as safely possible. In terms of those hubs will see, we've done an initial piece of work looking at how we'll divert referrals from primary care, social care, and from the specialist services through that hub. And again, the impact of that will allow potential transfer of resource from existing services, particularly in our Tuve, across into support further the work of the hub going forward. That work is dependent upon some of the flow through the hub in terms of the responsiveness of other services and specialist services to be able to meet the needs of people that have been identified. So I think we can share that in more detail as we move forward through that launch and introduction of the service. So happy to bring that back in more detail going forward. The hub itself is being governed by a delivery group, which is the voluntary and community sector and the statutory sector together. And that group will continue to report into the mental health partnership going forward, and then up to this group. In terms of the crisis line, of the crisis services, there's a bigger piece of work here in terms of the wider crisis or urgent emergency care for mental health response. So we've got a number of meetings that take place across the system, looking at right person, right care from a policing perspective and how all agencies work together to respond to mental health crisis, and ensure that an appropriate response from the right services in place. We've got our mental health act meetings that take place to support agencies in the delivery of the responsibilities under the Mental Health Act. And we've also got the what was you referred to the crisis concordat, but a quality improvement group that looks at how we deliver crisis services together across all agencies within the area. One of the things that was identified as an action from the crisis report that Healthwatch published was trying to streamline that and pull it together so it's coherent and feeds into the Urgent Emergency Care Board that covers Humber and North Yorkshire, and that work is ongoing in terms of aligning those meetings. An example would be the strategic delivery of right person, right care for the police. There's a meeting in April to look at how all partners get together to look at policies and procedures and some of the more strategic delivery of that programme across the area. From a crisis line and crisis team perspective, we're focusing very much on tube services in the area. We still do have some vacancies within the York teams, both in children's crisis teams and in the adult crisis team. And we are looking at more flexible roles that are going out to advert in the near future to try and attract people into those posts. We are using agency to support the level of service and maintaining the required standard in terms of response times, which is a 4-hour response time, but clearly we would always want to strive to do more than is purely required. The crisis line, the 0800 number that currently operates across the whole of York and North Yorkshire, we have recently moved to a new telephone system to help us manage those calls better and understand more about who's waiting for their calls to be taken, and have more transparency around about how we manage that across our services. Our new provider for call handling starts on the 3rd of April, and that's been made public now in terms of its Every Turn, who's a provider that will be joining us to do the call screening when people call the 800 number, and ensure that the calls are appropriately directed to the best person to meet their needs. So we're we're looking forward to that provider joining us and working in partnership with us. And I think they're going to bring some real new opportunities to work together across services when they join us. And then going forward, this is in preparation for a move to a national change in how crisis lines are operated in the future through NHS 111, and we're continuing to work with our partners in Humber and North Yorkshire in the implementation of that. Just for information, I think last week's information, I think the average wait time on the crisis line for people calling and being transferred to the crisis clinician was about 30 minutes. And there was 388 calls in the last week that came through to our crisis hubs, and we answered 70% of those before the person abandoned their call.
Thank you for the update. I appreciate all of that and all the work that is going on to try and turn this around. I'm afraid though, when you say that 70% get picked up, that means that 30% don't. So I still find that really quite troubling. That's a crisis line. That's a line that people are calling because they or a family member considers them to be in crisis. So therefore, you know, I appreciate your efforts, and I know that people are working really, really hard to improve that. But that is still a really worrying level of hang-ups, because those people will be ending up in A&E or worse. So therefore, we just, you know, we absolutely have to work harder on that partnership approach. And just, you know, if there are things, Brian, that, you know, you think partners can be doing to help with any of that, please bring those suggestions forward, either to this board or to the partnerships, health and care partnership, because I think, you know, residents we know that we've got a mental health crisis, and we know that we want to address most of that through hubs and early intervention, but actually at the moment we aren't yet at that place, and therefore we do need that crisis support to be operating as well as it possibly can. So I hear what you're saying, and I appreciate what you're saying. The only other thing I wanted to say on a completely light note at the end of this is I am on hub overload in that paper, because there were 3. There is a frailty hub, there is a mental health hub, and there is a family hub. I mean, it's just a plea to officers for a bit of creativity, really, because we're all, you know, I get the word is quite friendly and it feels approachable, but, you know, they are ultimately services and they don't all have to be called hubs. And I've raised this with Martin, and he's absolutely wedded to his family hubs, but we also have frailty hubs, and we also have mental health hubs. So I'm just, before we have any more, and I'm sure there are more, Brian, sorry, do you want to come back?
Yes, please, just for some clarity on that 70%, I think it's just important to know, obviously, we want to answer all calls that come through to the service. People calling the 800 number, at 94%, I think was the last report of the calls are answered by a person. It's then the transfer through that the 70% call rate is answered on. So people phoning the 800 number, over 90% of those calls are answered. In terms of the people, some of that 30% are people that hang up and then call back. So we can see in our system, people don't wait, they hang up, they redial and join the back of the queue again. So again, this communication there about asking people to stay on the line and wait, because they will be answered.
Thank you for that. That is really helpful to know. And look, I know that people are working really hard, in particular in light of, you know, discussions that have been going on for many months. Did anyone else want to come in on this report? Otherwise, I'm going to move on to the report from the director. Oh, no. That's why you're here, to make sure I don't do it in the wrong order. Sorry, we have swapped the agenda around slightly. We're going to move on to agenda item 7, which is the update on dentistry. And I am two of my most favourite people who work in the building, because they work on dentistry. Deborah Ledbetter and Andrew Hobson are here to talk to that report and tell us how they are resolving our dentistry challenges in the city, hopefully. Or at least the efforts that they're making to try and do that. So if you would like to talk to the report, and then I'll open up the floor. Thanks.
Thank you, Chair. So I'm Andrew Hobson, I'm the Deputy Director for Dental Commissioning working across Yorkshire and Humber. I'm just going to start by making a few remarks about the National Dental Recovery Plan to start with, if that's okay. And then my colleague Debbie will pick up just a couple of the more specific points around dentistry care in York itself, and then we can open it up to any questions. So last month, the government announced its quite long-awaited dental recovery plan, and I'm sure you're all mostly aware of this, but the plan commits up to £200 million of non-recurrent funding over next financial year to support access to NHS dentistry and to improve kind of prevention and oral health more generally. So there's a range of measures announced for kind of various players in the dental and oral health space, including a set of prevention-focused actions that are largely for local authority teams, and that's sort of all summarised at a high level in our report. We're really supportive of all of those prevention actions, but our report and my comments today are going to focus largely on the actions that sit with us as the NHS Dental Commissioners and our team. So I'll just summarise briefly the actions that we're taking forwards underneath that plan. So the first point that I'll talk about is the uplift in the price for a unit of dental activity to a minimum of £28. So this is one which probably isn't going to have a lot of impact for the City of York, just because we're kind of ahead of this, above this already. We've got an average rate that we're paying of already over £34 per UDA. There's only actually 4 practices that this affects across the whole of Humber and North Yorkshire ICB, and none in the City of York. We are working with the practices who are affected. It's only actually a sort of recurrent impact of £71,000 per year across the whole of the ICB to uplift those contracts to £28. It's really not much of our budget, not a huge amount of impact from that measure, just because we're already in general paying more than that. But we're working with those practices, and we'll be writing out to them to sort of confirm how we're taking that forwards. The bigger picture piece might be that the new patient premium, which came in at the start of this month. So this is a premium of £15 or £50 that is an additional payment for practices who are seeing new patients, so patients that they haven't seen in the last 2 years. And we're hopeful that this is going to act as an incentive for practices to essentially open up their lists and provide access to new patients. We've heard this is an issue. This is sort of something that we do hear, that practices are worried about seeing new patients that maybe haven't been seeing a dentist in recent years because of the amount of work that might be required to stabilise that patient, and they are concerned that our kind of current contract and how we pay for dentistry might not basically compensate them for that amount of work. So this is an additional payment to try and sort of rebalance that and provide a financial incentive. It's worth noting this additional payment only applies when the contractor is sort of up to their total contract value, basically. I haven't explained that very well, but basically what I'm saying is in practice, it's not really truly additional money. This is more about a sort of financial incentive within the current financial envelope to try and target our access on new patients. So that's just worth noting, really. It should still act as a financial incentive for providers. We're going to kind of monitor that and see whether contractors genuinely change their behaviour as a result of this money being available. It's only been available for a handful of weeks at this point, and so probably too early to kind of form a judgment on that. Two more measures that I'm going to just talk about briefly. There's the dental van, the mobile dental units that have been announced, and the Secretary of State for Health did confirm in the House that Humber and North Yorkshire are in scope of that particular initiative. It's not going to be available for every ICB. We're working with the national team to understand what this means. It's I guess what I can politely call an eye-catching proposal. It's not something that was kind of really on our radar prior to the plan being announced, and we don't have any mobile dental units at the moment operating in the ICB. So we're working through that one, and firstly we need to understand the procurement of the van itself, and but any service that we do run is likely to target sort of more rural communities, people with high travel times to dentists. So again, I wouldn't expect a big kind of impact there on the City of York. And then there's the Golden Hellos that was announced. So this is a payment of £20,000 over 3 years to try and attract dentists to areas where recruitment is particularly challenging. I don't have a hugely helpful update here just because we haven't yet received the details of which areas are going to be targeted in the country by that particular measure. I think what we do know is that actually money itself would be welcome if we're able to get that access to that here in York, but it's not actually enough on its own. And so if we do get access to that money, I think we'll be looking to have a kind of a conversation about what a wider sort of wraparound package of support might look like. So we just know that, really for dentists to stay and put down roots in an area, it's much more about clinical peer support, about kind of professional development, them seeing that they've got a kind of a longer term career in the NHS. And so we'd be thinking about what opportunities there might be to sort of build that support around any kind of payment that might become available to encourage people to sort of actually stay. So I think there's other things talked about in the plan that are worth mentioning. There's sort of broader measures on workforce that we're supportive of, and obviously those workforce initiatives are just essential and underpin everything that we're trying to do as commissioners. There's water fluoridation is mentioned in the plan. There's a consultation imminently launching about the fluoridation of water in the northeast. And we're really supportive of that as an integrated care board. There's huge evidence that that's sort of really the single biggest value for money action that we could take as a country to kind of improve oral health. And there's actually a small number of households up in the north of the ICB that are affected by that, would be affected by that fluoridation initiative if it was taken forward. So we're going to be responding positively to that consultation as and when it opens, and we really want to be kind of positioning ourselves as being able to sort of follow in the wake of that if that goes forwards. So I think all in all, in terms of the recovery plan, I don't think I'm going to sit here and say this is the sort of solution to all of our problems in terms of access to dentistry in York, but I think we do want to work really hard to maximise its impact, to understand the impact it's having. We're going to be implementing those measures as best we can, and working through the detail as it becomes available. But really, I think we want to go further locally. We think we can do that. We set that out. Part of that in our report in paragraph 5 sort of sets out some of the things that we can do kind of on top of the national plan, that hopefully will enhance the impact of those measures. And that's really where we're focused. So before I open up to questions, Debbie's with me. She's our programme lead for dental in Humber and North Yorkshire. I thought it might just be helpful to provide an update on the particular provider, Blossom Family Dental Care, that we spoke about last time, and then potentially we can open up to some questions and discussion.
Great, thank you. Debbie, do you want to come in?
Yeah, lovely, thank you. Yeah, I suppose because Blossom was mentioned last time, we thought it would be really important to address that and give an update. So Andy has been out to see the practice himself. I've been out to see the practice, and we're really pleased to say it's not a contract handback. We've been able to work with them positively to retain their NHS contract. We're looking at the way that that contract is delivered. We're agreeing some communication messages with the practice that they're happy to share. They're trying to get that balance right between saying, yes, they're continuing to offer NHS services without every patient ringing it and coming through and bombarding the practice again. So what they're saying is in terms of routine dental care, that they will be in touch with patients and invite them in as and when. But in addition, we've secured 12 urgent access sessions per week with them. So that's about 84 patients appointments, that's per week, including on a Saturday. So that should hopefully help with some of those urgent issues, getting some new patients into the system that can then continue on their books. So we're just in the process of doing those contract variations and finalising everything with the practice, but it was a really good outcome in terms of what we could achieve with that practice. And I think it speaks in terms of our priorities for wanting to engage with practices. If we can find out as soon as possible whether they're struggling, if they're thinking of handing back contracts, we can be creative, we can have that conversation, and we can really look at doing something differently to support them. So we are keen to keep building that relationship and looking at some of our other initiatives that we've got around spending plans that would include all of the practices across York, and it would help others like Blossom to engage in different ways of delivering their NHS contracts as well. So we just wanted to share that aspect. So I don't know if you've got any questions in particular about Blossom.
Great, thank you. That is genuinely really good news, and also a real kind of testimony to what happens when money shifts into a local area with people who understand the impact of those contracts being handed back and are then able to take some really positive, proactive steps to address it and to, you know, enable some more NHS dentistry to continue and not be lost from the city. So genuinely, thank you for the update. It's really good news. Sarah, did you want to come in?
Thank you. It does sound really positive. However, I am a little frustrated, as we discussed with the previous conversation, about the fact that a lot of this is non-recurrent. So I just wondered if you'd had any feedback from local dentists about how likely non-recurrent initiatives are going to be to, you know, to develop a sustainable long-term solution, because I don't think the waiting list and the challenges are going to go away in a year. And I think, again, as we discussed, it's really difficult to actually put in place, you know, additional staffing and capacity to support people when the funding is time limited and non-recurrent.
Yeah, completely.
Sorry, just before you come back on that, let me take Sian, who also indicated, and then you can come back on both things at the same time.
Yeah, I'm sorry. I know I'm the voice of cynicism when it comes to NHS dentistry on a fairly regular basis. And I think one of the things that really concerns me about this 200 million non-recurrent funding is I know from the Freedom of Information request we put in with the 50 million short-term funding that was released for flexible commissioning, none of that money was spent in York. So there is a real challenge for me about realistically how much of this money do we actually think will come to York and will be spent on solving the problems we have day in, day out with access. I absolutely appreciate that turning things around with Blossom was beneficial for the city, but in terms of those patients who are now left without an NHS dentist, without the means to pay for private dentistry, we still have a huge problem in the city with thousands of patients who have no access to support with their teeth. I'd really like to know how we can signpost people who we know are really struggling. So, for example, we've had cancer patients who can't eat because of teeth issues. How do we signpost those into those urgent care spaces if they are now available? And I think we all need to be aware of that as partners to make sure we're making the maximum use of that opportunity. But I think
over and above all of that, I know Healthwatch England welcomed the new recovery plan. I have to say, we, in a discussion in our office, didn't welcome the plan because it just doesn't go far enough. That contract needs ripping up. An actual co-produced solution with patients and dentists that addresses the reality of NHS dentistry today and delivers an oral health contract for our population is what we're all looking for. And I just think this is still fiddling while Rome burns. I would really, I don't blame either of you. I know we've had many conversations, Debbie, about this whole situation, but it just feels to me like this isn't enough. And I really want to understand how much of that money will come to York and will address our problems. And if it is just a one-off, is it just kicking the can down the road for more problems to be sitting on our doorstep in another year's time?
Thank you, Sean. Councillor Runciman.
Thank you. This is a question for the future. I'm really glad to have the report, and thank you both very much for coming. What I would like to have eventually is some metrics. I'd like to know where you started, where you've got to in reducing the waiting list, where you've got to in increasing the workforce, not just with dentists, but dental care assistants, whatever. I'd like to know whether there's a net gain or a net loss of dentists, because you've talked about that problem, and whether most importantly, we have less children going in for an extraction under anaesthetic. That means that your Smile for Life programme is working. So, Chair, if we could ask perhaps 6 months, because obviously you said it only started this minute, as it were, they could come back and just tell us a bit more, I think I'd be really grateful, and let's hope that that's a very positive report. Thank you.
Thank you. Councillor Waller.
Thank you, Chair. I'm grateful to correspondence I had with Deborah in advance of the meeting. I think the access for children to NHS dentistry is a key feature, particularly with attendance. If the option is to travel long distances, then that takes out most of the school day to attend. So it's really understanding what people will experience as a consequence of these interventions. And there was an issue of some underspends across the country were being reallocated. I think it wasn't clear what was happening locally with that to ensure that all of the available money was being utilised to provide NHS dentistry. Thank you.
Do you want to just come back on those points, and then I'm going to bring in Martin and Peter.
Yeah, lovely, thank you. Yeah, so I suppose picking up on the funding question, our dental budget is ring-fenced, and the ICB taken the view in 23-24 with any of our non-recurrent clawback funding that we would reinvest that within the system. So we've launched a range of schemes to look at reducing orthodontic waiting lists, increasing our urgent access sessions, other waiting list initiatives to bring down and incentivise patients, new patients to be seen by our practices. We've also committed to dental practices paying them up to 110% of their delivery. So usually they've got a delivery target, but we're able to pay that additional if they're able to achieve that. So again, that just incentivises that overperformance and helps to bring in more patients to access that dental care. Going forward into 24-25, that budget is again still ring fenced, so we can commit to spending that. The ICB is also taking a really positive approach in terms of managing risk. So similar to the conversation about kind of spending in the last few months when we know we've got it, we know year on year we have this fund that's available. So already we're planning actually from April, what can we continue to do? So that helps in terms of workforce and planning, in terms of access for patients. So we've already committed to continuing all of our flexible commissioning that's in place already in the city, and continuing our urgent access sessions that are available in the city. And then we're also planning what going forward we might want to introduce. So in particular, we've got a gap for what's called intermediate and minor oral surgery, IMOS. The furthest north we've got in Humber is Selby, so that leaves an entire gap for quite a large bit of the population. So we're really keen to fill that gap and actually go out to the service and say, can we get a service within York itself? Can we get a service further into North Yorkshire? So that is something we want to look at. Equally, the conversations that you've been having about mental health services, we aren't wanting to do a pilot to do mental health for those living in secure accommodation so that they've got access to a dentistry service as well. So we're keen to develop that pilot, and we're just working on the service spec now. It was out for consultation, we've had some comments, so we're just reworking that, and we'll be working with Clifton House to deliver that. And one of the key bits, kind of answering some of the questions as well about children, we've got an offer out for child-only contracts. We just finalised what that would look like last week in terms of the expressions of interest we've received. So we've not confirmed with the practices as of yet, but we've got 4 in York that will be going out to accept their expressions of interest and to offer what we can to those practices as well. So that is purely for children to come in and see an NHS dentist who've not been seen for the last 2 years. So that should increase access for children. And again, kind of looking at locations within the city itself, so trying to reduce that travel or having those practices along travel corridors so they're easy to access for families to get to those centres. In terms of signposting, I think, Sean, we're probably in that position now where we could share a list. I can't see why we can't be doing that about who those urgent access sessions are with, who our flexible commissioning practices are, so that just helps to signpost. And I suppose it's managing the expectation around that to say that doesn't guarantee that you'll be seen, but they are your most likely practices where you might get through. And equally, we've got a package of work looking at flexible commissioning, where at the moment the focus around that has been around prevention and access, and it relies on practices having oral health champions in place and doing outreach work in the community. And we actually want to expand our offer of flexible commissioning, making it more available to practices who perhaps aren't performing, because at the moment the criteria was that they had to be reaching 96% of their contract delivery. So we actually want to reduce that and say for practices who are reaching 80% of their contract delivery, you can still have flexible commissioning. Equally, we're going to allow them to twist more of the contract, so up to 20-25% of the contract they could deliver differently under flexible commissioning. And then part of that, we want to develop those pathways for patients like cancer patients to say that's the route in, and those are where you can be seen, because that's a key priority for us. And other health conditions and vulnerabilities, building in those pathways, not relying solely on the oral health champion kind of route where we have had flexible commissioning working really well. We're going to retain that, but we want to introduce different pathways as well in that. And then just picking up on the comment around metrics, I think Andy's working on a report at the moment actually where we're looking at what metrics we want to revisit regularly, and that's really useful to get your feedback on to what you would find useful. And I think within the ICB, Andy and I are still relatively new, and it's getting to know the different teams. So we're really keen to build those relationships with the population health teams, and Jack Lewis and Jake Abbas's team to kind of say what statistics and data have they got that we can help to build those metrics and model exactly like you say, to hopefully be able to see the impact and the improvement that we're making. And equally with our comms team and looking to build messages for patients around how to access an NHS dentist, what to do when you're in pain, preventative messages about good oral hygiene. So we're hoping National Smile Month is in May to June. It crosses over both months, to do some campaigns around that messaging as well for patients through National Smile Month. So we've kind of got those on the cards and in planning, which I think as part of an ICB, it just gives us more resource and more people and their expert skills in those areas that we can build on as well. So hopefully that will help to address some of those messages to patients and some of those metrics going forward.
Thank you. Did you want to add any? Great. I've got Martin, Peter, and I think Emma. Are you indicating? Yeah. Do you want to just before you come in? I just on the groups that you've identified for the ones that you're considering for the additional support. You've got child-only contracts, homeless and refugee services, and those in mental health facilities. I just wondered, and you've also got other schemes aimed at reducing waiting lists. I just wondered whether there were any other small groups that are particularly vulnerable to not having access to NHS dentists. I suppose off the top of my head, I was thinking of pregnant women who, you know, are particularly, that their teeth are going to be in a particularly bad state if they don't have access to an NHS dentist. But just there may be other groups that I'm not aware of. Healthwatch may be able to advise me on those. But that just whether there's anybody else we should be asking you to look at particularly. Diabetics, there you go, there's another one. But just particular groups where actually not having access to a dentist becomes a longer term health problem, and just whether it's worth adding those to your list now before you get too far down the track. I'll bring Martin in.
Thank you. Thought you were going to steal my thunder. That's okay. Didn't get there. So I think it's fantastic to see a children only contract. I'm really pleased to see that. I think just as a corporate parenting responsibility, which we all have a combined responsibility for within this room, to think about care leavers. So care leavers often have had a fairly chaotic experience through the care system, often various number of placements, and that can go on up to the age of 25, for which we have a responsibility for. So thinking about care leavers post 18, below 25, sometimes they may leave the dentistry system, and making sure that they don't just lose their NHS rights, I think is really important. So that's a particular group. And then finally, just a bit of good news and some metrics. I think some fantastic work has been done by the ICB, particularly around young people that are in care. So we have 91% of young people, 92% of young people who have been in care for more than 1 year who've got an up-to-date dental check, which is phenomenal figures actually. And something that is probably higher than I've seen up and down the country. That's gone up from 79% last year. So, you know, just like to thank the colleagues that have done some work around that particular group, because it's significantly improved.
Brilliant, thank you, Martin. And actually, I think that, again, I think this is also about linking up your team when you know that you've got a young person who doesn't have a dentist, and just having those pathways of communication open. I think that's really, really helpful. So I don't know whether that's what has caused that change for that 20% increase, but anyway, it's all going in the right direction, which is great. Peter, did you want to come?
Thank you. Yes. Smart for Life, a prevention programme. I don't feel like I quite understand implications for York in terms of any new investment, if any, in that. Would state at this point my absolute support for what Andy said about community water fluoridation, which is exceptionally well evidence-based in terms of safety, but also in terms of the outcomes we get. That's great, happening in the North East as a pilot, so interested to see what happens there. But thinking particularly about that Smart for Life offer, public health commissions a lot of oral health promotion programs, our toothbrushing in schools programs. Some of the flexible commissioning I know has had that public health route in, but anything that we can do to enhance that, and it, you know, family hubs does feel like a very good opportunity, but I'm just not sure from that section in the report if any additional resource comes our way within York into the family hubs model or into any other model. So, you know, a blatant ask about, is there any new resource within that?
Do you want to come back on that, and then I'll bring Emma in?
So I'll do my best. I'm afraid I don't know the answer to that in terms of the financial kind of resources associated with the Smart for Life programme as is announced in the plan. So, and as I say, sort of, I guess we have been focused on the actions that sit with us as the ICB, as dental commissioners. So I'm happy to look into that outside the meeting, but I'm not able to provide an answer to that one today.
Emma?
Thank you so much for this report. As you probably know, the the provision of dental services or the lack of has a massive impact on general practice, in fact, the whole health system. So I guess really welcome that there is some resource coming through. I guess of the two things, particularly Deborah, that you mentioned, one was if you've got some resource and some signposting, please tell it, because at the moment we are becoming the first port of call general practice for dental problems. Puts us in a very awkward position because we should not, and we try and have this message, but it's very desperate when you've got someone with fever and in pain to neglect their care. So we end up treating things we shouldn't, we know we shouldn't, but what we need is that. Otherwise we say 111, then we go around this loop. So anything you've got resource wise, please let us know, because if we can put it on our websites too, we can just make sure that that information gets to the right people. Then my last aspect was about the metrics when you do the evaluation. So obviously we need to know the footfall through what you're commissioning to try and make the best use of that recurrent money. But I'd really plead that it's triangulated if you can with primary care attendances for dental care and A&E attendances, because having done a big audit of A&E attendances, dental care is still massive. The letters back for max facts are getting more and more terse, we are not a dental service, back to the dentist, and there's a poor patient in the middle of that bouncing around the system. So and this is bad use of resources. So we're spending health money on dentistry. So it might help the case to build for the recurrent money, which we're totally behind you. So yes, those are my two pleas. So yeah, just add us into that data collection, because if you can show impact on that, then that helps to show that it's working. Thank you.
Great. You see how excited everyone is that you're here. I'm keen to move on, but just a couple of things. Just on the child-only contracts, just something that struck me that it might be useful if Martin is able to share with you information about the particular schools where we might have concerns about which children which areas of the city should be a priority in terms of accessing those places first. Otherwise, it will become the ones who shout the loudest who get in first. And then my second point was kind of related to that, which is at some point, what public information is going to be available around those pathways and where people should be going, because and which practices are taking on patients, because at the moment that information on the NHS website is broadly fictional, and basically is down to whoever is the most persistently going through those numbers week after week after week and happens to hit on a practice that maybe is taking someone on that week. So it would be just at whatever point that is then appropriate to update that public information, because we know that there's a problem. We know that you're doing your best to resolve it, and we're all, as you can hear, very, very grateful. But we still quite a long way from having information on a website that enables patients to just contact a surgery and get registered with an NHS dentist, which obviously is the goal that we would all like to be reaching. Great. Yes, did you just want to come in again? Sorry.
It was just one more good news story as well for York, because as we were able to procure a new dental service following the handback of the Bupa practice. So that is still on track for summer to be opening. So again, we'll be working with that provider to again manage patient messaging, because you've probably seen the news a few weeks ago with the queues in Bristol. So we want to avoid that. So we'll be trying to manage that messaging. Patients who had been patients at Bupa will get a letter, so they should have priority. But again, the practice will be needing to prioritise and kind of triage and assess those requests to join the practice. But we'll be working with them to manage those messages. And equally, if you've been into the Stonebow area of the city, you'll have seen some work in progress around there. So my dentist is relocating to the Stonebow area, and they're on track as well to be opening in May at some stage. Again, it's not a new contract, it's the existing contract, but the new facilities may be able to open them up to take on some more patients as well. So we're working really close with my dentist to manage what services could be delivered from that practice as well.
Amazing. Thank you both for your time and for all of the work that you're putting into this. The residents of the city are very grateful. So thank you. And I can't guarantee that we won't come back to this quite soon, but nevertheless, for now, thank you very much for your time and for your report, which we welcome. We will move back to what was the original agenda item 6. Which is the update, the public health update on the joint health and wellbeing strategy, reducing health inequalities in specific groups. Peter, I assume this is you, yes.
Thank you very much. Yes, so we have a health and wellbeing strategy, 10 population health goals, which we think will get us some way towards the overall goal of reducing the gap in healthy life expectancy between the poorest and richest communities and other inequalities gaps within the city. So what we do as a health and wellbeing board is take a number of the goals, or in this case, one goal each time, and focus on it a little bit. And so today, focusing on goal number 6 from the strategy, reducing health inequalities in specific groups. And this was one of the goals of the strategy, I guess, which probably benefited from a little bit more definition, and it was because it is quite a broad goal. What I've done in this report is to just lay out some broad background about what we mean within the strategy when we talk about specific groups, and health inequalities can affect the population in lots of different ways. We could be talking about inequalities across different protected characteristic groups. We could be talking about inequalities across geography, but then there are inequalities across particular other groups who aren't bounded by geography, and we know that they experience worse outcomes than others within the population. And that's really what this goal is about. It's about looking at particular groups within our population who are in some way easy to ignore, marginalised, a number of terms you could use. The NHS would use this term inclusion health, which I think is helpful, if sometimes limited, to talk about the inequalities that those types of groups experience. I draw attention to section 10, which has, I think, one of the most devastating public health graphs I know, which is about mortality across different groups within the population from a poverty perspective, I guess, from the least to the most deprived communities, but then set against a further bar, which is our excluded groups, and the very small print, which is possibly impossible to read, but explains essentially who the excluded groups are, but generally talking about homeless individuals, prisoners, sex workers, individuals with substance use disorder, and the exceptional rates of mortality that people in those communities experience. And that is also set against comments from a public speaker earlier on, demonstrating a 4-fold excess mortality in those with a severe mental illness. We could say the same for those living with a learning disability. Average age of death, someone who uses heroin is 52, etc. We know these inequalities are very acute. The report then goes through a number of different categories of groups, cohorts within our city, and hopefully gives some useful, if limited in some senses, data and points that we draw from joint work we do with ICB on inclusion health across racially minoritized communities, people experiencing homelessness, people who are dependent on drugs and alcohol, our Gypsy Roma traveller communities, the whole area around vulnerable migrants, refugees, asylum seekers, and new migrants to the city, sex workers. We have added a section in students not because actually in general students experience better health than the rest of the population, mainly due to the fact that they come from a certain age range. However, there are some areas in which our students in the city do experience worse health, and there are inequalities. And as a city with a lot of students we need to be really mindful of how we are providing and helping them with their health needs. Carers as another group within that, transgender and non-binary people, veterans, and yeah, that's at the end of the list. So just pulling out a number of areas there, and no time to go through the data on each group in turn, but hopefully a little bit of context on each. The report then goes on to talk about what actions do we have against these things, and this is hugely broad. And I think what we did say to ourselves as a board is that actually fewer actions where we had a chance of doing something rather than more actions that were just words on a page. So admittedly, the actions I'm going to lay out probably don't tackle the breadth of the need that I've laid out in the report. But there are 2 actions under this goal in the strategy, A14 and A15. A15, I might actually invite others, particularly from the CVS, into comment. The action here was written by Alison from York CVS around the Poverty Truth Commission, which isn't something I personally am involved in, but I'll quickly run over action 14, which is about using our health inequalities grants to fund targeted work, including by local third sector organisations, to enable them to address health inequalities. And so the page in the report, page 9 of this particular report, covers a number, over 10 different funded pieces of work that between the council and the public health team and the ICB, we have funded across the last year using ICB resource, which are aimed at targeting many of the groups that I've mentioned so far, including work around maternal and child nutrition, including some contribution to York Hungry Minds campaign, work around asthma-friendly schools, the Brain Health Cafe, which is relevant to previous conversations this evening on dementia diagnosis rates, but also those who are waiting for a diagnosis and supporting them with cognitive decline and worries about memory, mental health related school absence work. The Ways to Wellbeing Small Grants programme covers a good 10 to 15 activities actually, so that in itself has an awful lot of third sector work around health inequalities wrapped up in it. The wonderful Health Mellow, which was held last September and is again, I don't know if I'm allowed to announce this, but anyway, it's happening on the 22nd of September this year. So that is happening again, and date for the diary, which is around, I guess, ethnicity and health. The GP outreach at the Women's Centre, which is working a lot with women, variety of needs, including some sex workers and other vulnerable women. Our work around wellbeing activities for asylum seekers and refugees, work within family hubs, particularly at communities and families with young children in from marginalised communities, work around homelessness with Peace Home, and then citizens' advice in GP surgeries. So hopefully a good representative range of projects that we've done in fulfilment of this action. Action A15, as I've said, is about the Poverty of Truth Commission. So I'll let other colleagues come in on that. And then as an annex to the report is just some of the data that lies behind this. So that's all for me, Chair, on this, and happy to take any questions.
Great, thank you. Sarah.
Thank you. It's a really comprehensive report. Notwithstanding, there's probably a lot more that we could say about each of those categories, but I just wondered what we know, what intelligence do we have about people who may fit into 2, 3 or more of those groups, so what we describe as severe and multiple disadvantage, and are there any specific initiatives that are targeting people who are, you know, in more than one of those categories and therefore might fall between some of the initiatives that are specific to each? Thank you.
Do you want me to take a couple more just so we then
Great idea,
come back
yeah.
on everything?
I'll take
Councillor
the notes.
Runciman.
Yeah, I'm sorry, Sarah, I didn't catch everything you said, but what I'm wanting to know is the outcomes. We're into metrics again. You put a comment in the Women's Centre work. It's having an impact on building trust, and I was really pleased to see that. That was very good, but it'd be really useful, I think, Chair, to know which ones are working, which ones may need some more attention to them, be more developed, so that we can see that the time and money that have been invested are actually producing an effect.
Thank you, Sian.
Yeah, I just wanted to make a couple of points about some of the contents of the report, just to say we have raised the issue of gender identity clinic waiting times with the ICS, because we know they are incredibly long, and we also know that particular group of people have a much greater rate of mental health issues, and also find waiting to not be able to be entirely themselves incredibly challenging. So I think just raising the fact that we know that that waiting time is very, very long at the moment, and we have raised it, and we understand the ICS are looking into it, which I think is useful for us all to know. But I also thought it's worth raising that the health outcomes for deaf people are considerably worse than the rest of the population, despite the fact they actually live healthier lifestyles purely because of the barriers they face in accessing health and care services and getting support. And we still don't have solutions in terms of making sure that they can have interpreters for a range of appointments. I know the hospital has done lots and lots of work, but still members of staff there don't always know how to access the online interpreter service that can be provided in an emergency. And there's still issues with booking face-to-face interpretation. So I just think that is a health inequality we should all be mindful of, and is well documented.
That's really helpful. And I'm just going to give you my 2 pence, Peter, and then you can come back on all of it. Just a few things from me. Just on the voluntary sector point, I think it was action A15 on page 50. I particularly welcome the update around treating people with kindness, respect and understanding. But I guess my challenge would be, how do we embed that more widely across, agencies and bodies across the city? It is absolutely where we need to be going, but it doesn't always necessarily feel that is what happens. And I think if you're talking about some particularly marginalised groups, that is particularly important. If they're not going to have barriers to crossing the threshold of accessing a service. And my other query, page 55, the data, both on page 55 and in the table in Annex A, oh, it's not 55. Anyway, wherever, but the data in Annex A, page 53, I think it is, sorry. The data is old, around excess mental health deaths in adults under 75. I just wondered when we could expect an update on that data. It's marked as red, but it's also not updated since 2021. So I just wondered whether we could understand what that actually means more recently. My other query was on page 57 of Annex B, I think it is, yes, around employment rates for those with learning disabilities. That our gap is wider than the national and regional average, that struck me as concerning. And I just wondered whether someone could investigate that and whether or not there is something underpinning that in terms of either a lack of service or a gap somewhere in terms of employment support. And just on the point that Sian just raised about barriers to health access for deaf people, the sensory services contract is going to executive pretty imminently. So I'm just wondering, actually, Peter, whether it might be worth you looking at it before it goes to exec from a health inequalities perspective, just to ensure that we've got the spec that is going to exec right, and that we're not missing an opportunity to tweak it slightly before we make a decision on it. And David has indicated, sorry, David.
That's quite all right, Chair. I know, but because the Poverty Truth Commission came up, I'm just going to say a couple of quick things. I am myself a member of the Poverty Truth Commission. I am one of the so-called civic commissioners. Self-evidently, I'm there because the voluntary and community sector, in all its shapes and forms, works a lot in the area of people experiencing poverty or on the brink of poverty, or perhaps who have previously experienced that. And I'm not going to steal the thunder of the Poverty Truth Commission, which will be publishing its report next month, and there will be a public event for that. The headlines are in here, but what I will say, because you've asked this very question, how do we make sure that we embed it? And the discussions within the Commission, which will continue tomorrow on this topic, are very much about the individual organisations around the table promising that they will take actions from the point of recruiting staff and volunteers through to monitoring what they do, setting standards, and then checking that those standards are being met. All of those things require an incredible commitment on the part of individual organisations from the very top. And that is one of the main reasons why the Poverty Truth Commission principally, as far as the civic commissioners are concerned, principally comprises people who are at the very top of their organisation. So if I just exemplify City of York Council, we have the leader of the council and a very senior member of the staff. And their contribution, along with others, has been absolutely fundamental to this, because it is a question of saying it's all very well us as senior people thinking, yeah, we agree, we should be kind and we should do these things, and written correspondence should be in plain English. It requires action, not just today, but tomorrow and next year and the year after. And I'm using this moment, because I'm not a standing member of the Health and Wellbeing Board, to make a plea that once the Poverty Truth Commission winds up in its present form, there needs to be someone who is holding that together and asking how we are carrying this through, in the same way that the Health and Wellbeing Board looks at Healthwatch reports and says, what are we doing about them? And at the moment, I don't have an answer as to how we're going to do that in 12 months from now and 24 months from now. And this is, in some senses, not the right forum, except that several of the organisations sitting around this table are involved in the Poverty Truth Commission. So it's from that point of view, I'm saying I hope that we can not just applaud the work that's been done, because it's been a profound experience for me personally, but agree as a city that we're not going to just say, thanks for the report, goodbye.
Very well said. And I think that the broader point that you're probably making is around leadership and how people then take forward what the recommendations are and then implement it. And that is down to the leaders in their widest sense of the city doing that within their own organisations or within their teams or whatever it may be. But that's how you deliver that change, isn't it? So, Peter, sorry, we've all talked a lot, and now you need to respond on all of that.
Yeah, I've got a list, and I'll be very, very quick. So severe and multiple disadvantage. It's a great point, and we've done quite a lot in the city around multiple complex needs over the last 2 to 3 years. And I think I see that work evolving now, and particularly in my area, quite an emphasis. And we had a drug and alcohol partnership board this week focusing on dual diagnosis and that overlap between alcohol, drugs, and mental health, and quite a bit of focus on the ways in which often systems with professional structures and ways of thinking about, for instance, trauma are quite siloed, and actually we need to communicate much better with one another and potentially mix professional practice up so that those, for instance, who have an addictions background and are trained in addiction support understand the interaction of alcohol with psychosis or things like that, and are a lot more able to understand where's the best place for the patient at any one particular time. I think there is also the other overlap is housing just gets into everything, doesn't it? Housing is just hardwired through all aspects of severe and multiple complex needs. So there is quite a bit of work the council is leading at the moment on resettlement and the way in which we have a pathway for both children and for adults in terms of housing that is responsive to severe and multiple disadvantage. I think over the next few months that new approach is going to become clear through executive papers that will be published on resettlement. So I won't say more about that. Outcomes from Councillor Runciman. For the schemes that I've summarised here, there is actually a larger, broader paper which talks a little bit about some of the metrics that we're setting at the organisations who are delivering this. Because the governance of that is through the healthcare partnership, that's where that larger, broader paper goes. But absolutely, I think we'll be bringing this back when we next talk about goal 6. And at that point, it probably is the time to be able to say, well, what impact have we had on some of this? Quite a lot of it is early funded schemes, maybe the last 6 months. So, I think there's a little bit of time for these schemes to bed in, but we're going to definitely come back with future work on that. I will take back the gender identity waiting time, clinic waiting times. Obviously, there is, I'm pretty sure that's Commission actually NHS England and not ICB. So I think there potentially is, a difficulty in terms of the commissioner sitting at a national, but we can take that back to the ICB. And I think from my hearing from various different people around the table that actually this report in future, including the needs of probably those with sensory issues, both visual impairment, those who are blind, those who are deaf, as one of those inequality groups would be welcomed. So I'll take that away and we can do that piece of work. Excess deaths, I just looked it up. The data was published last March, So one generally expects with data that it's refreshed every year on that, but that still means it's got a 2 or 3 year time lag, and it's just very unhelpful, isn't it? And unfortunately, I can't do much about that because it's a national data set, but hopefully we should be getting at least a year's more. I did look at the sensory service contract, Councillor Coles, so we've had a public health input into that in terms of inequalities. I think that was all the points. Apologies if I've missed some.
Great, thank you. Caroline, you wanted to just come in, and then I'm going to move on because we're going to run behind.
It was just a very quick question around the gypsy traveller element. I mean, obviously I was struck by the data for all the communities, but particularly the gypsy travellers statistics is stark, really stark. What work is being done specifically around that community at the moment?
So we've published a health needs assessment, which is now on the council's website for our gypsy and traveller population who are both living on sites, but also in bricks and mortar across the city. We are bringing forward a gypsy traveller action plan for the city too, which has there is a multi-agency group which meets and talks, including the York Travellers Trust represented on that. So there's quite a lot of work on there. I'm really happy to almost summarise it in an email to Caroline afterwards. I'm sure it's not, you know, we could do a whole lot more, but I think there is quite a bit going.
I actually think it's in the next agenda item under the strategic needs assessment. Thank you to Tracy for that. So I'm claiming credit, it's not me. So we will move on though to agenda item 8, which is you again, Peter, with Jen Irving. Thank you. You're very welcome. Come and join us at the table. If you'd like to talk to the paper briefly so that I can attempt to keep us to time, and then we'll take some questions and comments. Thank you.
Yeah, absolutely. Thanks, Chair. So this is the annual update that we bring on the health needs assessments that we've done over the last year and that we're planning on doing in the year coming. So it is by its nature a little bit of information on quite a lot of things. So bear with me. So we've done quite a few over the last year. We've just spoken about one of them. The one which I'll talk about very quickly. So we did a gypsy traveller needs assessment, and this was a really taxing piece of work to do because there is so little information published, and the community by its nature is not an automatically easy group of people to engage with for very, very valid reasons. And that's ultimately one of the findings that we had. There's the places that we would normally go to for that information, we can't. And so the recommendations are off the back of that. And as Peter was talking, there's a group that's set up that's working to address exactly those things. The needs assessment was also used really recently in the local planning process that we have. So our sort of big strategic plan of where houses and other key infrastructure is being built. It was a key piece of evidence that was put forward there. So it is being used, but I would say that it is frustratingly limited in some regards because it's such a tricky document, but it's got the ball rolling. Other pieces of work we've done over the last year, we hosted a GP in our public health team for a little bit of time, and he did an end of life needs assessment. And again, a very sort of underexplored area. It's brought a lot of daylight to an issue, got some actions going, and some further data sharing work is kind of happening in the background to further explore that one. We also did a drug and alcohol needs assessment over the last year. The primary purpose of that one in particular was about recommissioning our drug and alcohol service as a city. So that work was really to hone in on what the priorities are, not only for the group of people that are currently accessing services, but the very large group of people that in theory could, but are not. So yeah, to bring daylight to that issue and make sure that we're asking our commission services to do exactly what the city needs them to do, basically. The JSNA process is also wrapped up in our population health hub. So this is a small group of people that sort of local authority and ICB together, and we've done a series of pieces, and I just wanted to put a little shout out to our learning lunches, which you're all very, very welcome to join. We have such a broad range of topics. We recently had one on Ramadan, and I learned so much about fasting, cultural practices, the health aspects of fasting, which was really what it was about, how to make sure that people can celebrate this really special month in a healthy way. So yeah, very, very warm welcome for you all to come to that one. So that's a really quick summary of the projects that we've done. I'll probably pause there because I've mentioned lots of headings and not said a lot of detail, and just say if anybody does have any really particular questions, and then I'll move on to what we've got planned for the year coming.
Wonderful, thank you. Does anyone have any questions for Jen, Sian? God.
Sorry, I just wanted to check, this is entirely because I have no idea, I am completely ignorant of this. With the end of life health needs assessment, is that linking in with the establishment of the Bereavement Alliance and how we might sort of support people around that? Because I thought if there's 5 recommendations for partnership working and we're setting up a Bereavement Alliance and it's all around end of life care and bereavement is sort of at the end of that journey, would it be helpful to kind of tie those things together, and have they already been or not?
It feels very sensible. I don't know. I would think yes, but I'm going to take the note to triple check that that is happening.
Brilliant. Thank you.
I could probably pick that up with you, Jen, because I've been doing some work on the Bereavement Alliance, and I know it has fed in, but maybe you and I could have a conversation. That'd probably help.
Perfect.
Brilliant. Anybody else want to come in before Jen talks us through what's coming this year? At risk of catching up. Jen, yeah, do you want to fill us in on what's coming up in 2024?
Absolutely. So lots of exciting projects. The one that I'll just highlight first is we have a new website, which feels like an incredibly long time coming. Our current website is an embarrassment, truthfully, and I almost don't tell people that it's there when people want documents. I just send them the documents because the website just makes me cringe. But it's a very inaccessible thing, and if you use technology to read websites and that sort of stuff, it just isn't fit for purpose. So it's very, very exciting. I was hoping to have slides for you, but there's a national organisation doing a rollout of something I don't understand, but hopefully by the end of the month we will have a lovely new website, and I will make sure that you are all very aware of it and you can enjoy it as much as I will. We are almost at the end of our SEND needs assessment. So this is special educational needs and disabilities. So this involves youngsters who are from birth up until the age of 25 who have a special educational need or a disability who are in full-time education. This was a piece of work that the SEND board had asked us to do, and we're just drawing that piece of work to a close now. I won't go into lots of detail on it. I understand that Maxine, who is the Assistant Director in Education, is wanting to bring a paper to talk to you all about it in a lot of detail. So I will absolutely let her do that. But it's, yeah, a good piece of work that we're coming to the end of. And then I just, in the paper, talk about the few things that the headlines of the papers that we have planned for this coming year. So we've just started scoping one out around neurodiversity, which clearly has links to the previous one, but the focus is a little bit different. So autism, and possibly also ADHD, and possibly also neurodiversity. We're very keen to make sure that we get the scope of this one right. So there are different camps and different ways of thinking about how we get that scope right, and making sure that we get that, making sure that it works for the community, that it's led by the community, and yeah, just makes sense. So I hesitate to put a title on it yet, but that is our next piece of work. And then subsequently to that, we have projects planned around women's health, around gambling. And then I've put in a note at the end, because I know there were discussions about it earlier on, that our planning cycle is just starting for our next pharmaceutical needs assessment, which is one of those statutory ones that there's a sort of annual or 3-year cycle that everybody in the country kind of lines up with. But it takes quite a long time to write, rightly so. So we're just in the starting of our planning process for that one.
Brilliant, thank you. Just a plea on the pharmacy work, that you differentiate between big and small pharmacies, because I think that's clearly where where some of the challenges are coming from, in the smaller local and rural pharmacies versus the big ones co-located in other facilities, or what, you know, where there is, even if a service closes, something else would probably step in. It's those small independent ones that feel like they are the real risk for us going forward. And obviously I've just had a look at your website, just so that I've now set in my mind what it is that you're the before of your after, and I look forward to seeing the new one. maybe without stretched photographs. Great. Does anyone else want to come in on that before we move forward? Amazing. Nearly on time. Sian, this is the Healthwatch report on community pharmacy and survey results. Did you want to say a few words before we open it up?
Yes, and thank you, Chair. And I promise not to take up too much of your time tonight. I know everyone is watching the clock and thinking it's nearly home time, which is lovely. But this report is here for information. It does not include any recommendations, but I hope it does serve as a useful reminder that although not directly represented around this table, pharmacies are a vital part of our health and care system and have actually come up in most of the conversations we've had tonight. They are the walk-in health service within easy walking distance of most of our population, with some notable exceptions, again, that we've already covered. We were delighted to work with Community Pharmacy North Yorkshire and Healthwatch North Yorkshire for this work. Our aim was to help set a baseline for understanding public satisfaction with current services and an understanding of the public's understanding of what pharmacies can offer. It's not huge numbers, and I would say we would hope to get more if we run this again, which we intend to, but it is a start and it's given us a target to beat next time. We found generally people had a positive view of their local pharmacy, with nearly 6 in 10 people visiting monthly, most often to pick up prescriptions. And pharmacies across York and North Yorkshire dispense 1.25 million items each month. So that's quite a lot if you think about it. Just over 50% of respondents rated their pharmacy as excellent or very good, with just over a fifth saying the service is poor. Some of the issues that were raised with us were the time taken to get a prescription and that medications were not always available. So within our report, we've included the journey of a prescription to try and set out why it can take up to a week to fill a prescription, as we believe there is a clear mismatch between what pharmacies can do and public expectation at this time. The work also tells us something about the demand in our system, as more than half of respondents identified that their GP practice is still their first port of call for all healthcare advice. Next, nearly a third looked at the internet. Fewer than a quarter of respondents went to their pharmacy first. We were quite disappointed to see that, but it reflected feedback in our recent urgent care work, where only 3% of respondents had been to a pharmacy before going to the urgent treatment centre. We believe community pharmacies can play a vital role in delivering primary care support and can help to reduce pressures on the NHS, including local A&E services. With the introduction of Pharmacy First, under which pharmacies can now prescribe treatments for 7 common health conditions with specific age restrictions around that it's really important we talk about because some of the national publicity hasn't. We encourage people to start with their local pharmacy for healthcare advice. So I really hope the board finds this of interest. I hope it poses some questions for us all on how we can make sure everyone's getting the best out of what we can collectively offer. And I'm happy to take any questions.
Thank you, Sian. I'll kick off because I've got a few things written down already. My first was just a question really, and it's probably not even really for you. It was a wider question about any other thoughts, given the bar charts of what currently people are accessing from their pharmacy, what might drive more people into their pharmacies. Blood pressure checks look very low in terms of those numbers that are going in at the moment. Whether there's anything else, I was quite surprised that vaccines aren't on that chart, but they are on another chart of their own, because I definitely got mine in the pharmacy this time. And so just that kind of wider point really for the room, that your response, you next time you do this report, you need to get more men to respond. And then just a plea, and I think it probably is a plea to Healthwatch, but just a general pharmacy plea for Christmas and New Year openings to be more widely made available, not least seen as I drove around York between Christmas and New Year looking for a pharmacy that was open and not being able to find up-to-date information after my trip to Bradford for an emergency dentist. So a little kind of health in action over Christmas and New Year, but that just is a plea that information is made clear, whether it's by you or someone, so that people know that you are the go-to place, or wherever is the go-to place for that information. I will have a look to see if anyone else has anything to say about pharmacies before we come. I'll come back to you, Sian. you can just finish off.
Lovely, thanks. I mean, I absolutely agree. I think one of the things that would drive more people into pharmacies is an understanding of what the pharmacy can already provide. And I think many people don't understand that you can just walk in and get a blood pressure check in a lot of pharmacies. Lots of people don't understand that you can just go in and ask for health advice if you've got something that you're not entirely sure. And if they can't support you, they will tell you to go to your GP or wherever else they think is appropriate. But they, you know, you can just walk in and ask advice. And in some of my visits to pharmacies, I've seen people who've walked in bringing flowers to thank people for the advice that they were offered because it solved their issue very quickly. So I think just all of us talking about what you can access at a pharmacy and the fact that it's worth a try. If it's 2 minutes down the road, you go in, they can't help you, you've wasted 2 minutes, whereas you could be waiting a lot longer in lots of settings in the health and care system. So just try it. I would plead to the public, just try it. And I do recognise the plea about Christmas opening times, because there's two different sources of information, which is who's open extra and who is routinely open over that time. We do try and share it in our Christmas services newsletter, and I know there was some work from the York Health and Care Partnership last year to put out more information about how to direct people over that period. But I think a shared understanding and a shared resource that we all signpost to that gives you that information easily was a very good idea, and I'm happy to take that forward.
Great, thanks. I think that's ultimately a comms challenge, isn't it? In a kind of wider sense of both services that pharmacies provide and also when and where you can access them. I am delighted to say that I am only 2 minutes over. Carol can make her parish council meeting. Everyone else is released to go to their homes and families. Thank you all for your time and your input and your expertise. And we will reconvene at the next meeting. Thank you.